Hello everyone, welcome to this session. Please let me know if I'm audible and visible so that we can start with the session. Yes, okay, thank you. So we'll start with the session. Today's session is an important session for the FMG exam, which is one-liners. Because see, I believe that one-liners never go out of fashion wherever, whatever is be the exam, whether it is NEET PG or FMG. Because even if we expect questions which are clinical or case-based, of course, there will be some one-liners, and one-liners are really scoring, and we must not miss them. Right? So let me just go over the questions once. So this is the first question. The epithelium of the cornea is. The epithelium of the cornea is. So the options given to us are columnar epithelium, cuboidal epithelium, stratified squamous keratinized, stratified squamous non-keratinized. So which one do you think we should choose? Which is the answer here? Cuboidal, columnar, stratified squamous keratinized, stratified squamous non-keratinized. Very good. Stratified squamous non-keratinized. So it's not just the epithelium of the cornea. If the question is the epithelium of the cornea or the epithelium of the conjunctiva, it is stratified squamous non-keratinized. And if we are asked what happens to the epithelium in xerophthalmia or vitamin A deficiency, then which options will you choose? Which option will you choose? If we are asked that in xerophthalmia or vitamin A deficiency, what happens to the epithelium? What does it become? In case of xerophthalmia, that is vitamin A deficiency, then see, it is going to change to stratified squamous keratinized epithelium. Right? So stratified squamous non-keratinized epithelium is the normal epithelium, whereas in case of xerophthalmia, it changes to stratified squamous keratinized epithelium. This is important for exam. And if we are asked what is the epithelium of the crystalline lens, then what is the epithelium of the crystalline lens if we are asked? Then see, at the center, the epithelium of the crystalline lens is cuboidal. Cuboidal epithelium at the center, and the same epithelium as we move towards the periphery becomes elongated like this, and it becomes columnar. So like there are 3 or 4 one-liners from here. I will just quickly repeat it. The normal epithelium of cornea conjunctiva is stratified squamous non-keratinized. In xerophthalmia, that is vitamin A deficiency, it becomes stratified squamous keratinized. What is the epithelium of the lens, of the crystalline lens? At the center, it is cuboidal, and at the periphery, it is columnar. Okay? So these are the one-liners from here. Let's move to the next question. Where do we get to see Horner-Trantas spots? Where do we get to see HT spots or Horner-Trantas spots? Where do we get to see HT spots or Horner-Trantas spots? Lictennular conjunctivitis, vernal keratoconjunctivitis, trachoma, adenoviral conjunctivitis. So, who will tell me the answer? Correct. The answer is vernal keratoconjunctivitis or VKC, and the other name for this is spring catarrh. Spring catarrh. So, Horner-Trantas spots, these are seen close to the upper limbus. These are close to the upper limbus and they are seen in VKC. Right? And if I tell you that where do we get to see Arl's line or Herbert Spitz, and the same options are given to you, which one will you mark? Arl's line and Herbert Spitz. In which condition do you get to see Arl's line and Herbert Spitz? Where do we get to see Arl's line and Herbert Spitz? If we have the same options, then which option will be marked? Very good, it is trachoma. So Arl's line and Herbert Spitz, these are seen in trachoma. Okay, so Horner-Trantas spots in VKC, Arl's line and Herbert Spitz are seen in trachoma. Next one liner. Where do we get to see Fleischer's ring? Fleischer's ring is because of iron deposition. It's a pigmented ring because of iron deposition. In which condition do we get to see them? Pigmented ring due to iron deposition. Fleischer's ring, where in which condition do we get to see? Very good. They are seen in keratoconus. So this is because of deposition of iron. It's a pigmented ring at the base of the cone. Similarly, in pterygium, there is a pigmented ring at the head of the pterygium due to iron deposition. Can you tell me what is the name of that line? Pigmented line at the head of the pterygium due to iron deposition. What is the name of that line? Pigmented line at the head of the pterygium due to iron deposition. Does anyone know? Okay, let me tell you, please memorize this. The name of the line is Stocker's line. Stocker's line. So pigmented line at the head of the pterygium also because of iron deposition is Stocker's line. So Fleischer's ring is in keratoconus and Stocker's line in pterygium. Both of them are pigmented lines due to deposition of iron. Okay, next question. What is the expected refractive error in keratoconus? What is the expected refractive error in keratoconus? Do we expect hypermetropia? Do we expect a simple hypermetropic astigmatism, irregular myopic astigmatism, or do we expect a compound hypermetropic astigmatism? Very good. The refractive error in keratoconus is an irregular myopic astigmatism. Irregular myopic astigmatism is the refractive error in keratoconus. And please remember one more one-liner MCQ that can come from here. Because of this irregular myopic astigmatism, you get to see the scissoring reflex on retinoscopy. This is also an important MCQ. This irregular myopic astigmatism gives rise to scissoring reflex on retinoscopy. So when you do a retinoscopy for this patient, you will get a very typical splitting reflex which is called as the scissoring reflex. So refractive error, irregular myopic astigmatism, retinoscopy, scissoring reflex. Next question. What is the drug of choice for HSV dendritic ulcer, or if I ask you HSV geographic ulcer? Both the answer is the same. HSV dendritic ulcer, HSV geographic ulcer. What is the drug of choice? What is the drug of choice for HSV dendritic ulcer or HSV geographic ulcer? Very good. The answer is topical acyclovir. Topical acyclovir. Now see, both this HSV dendritic and geographic ulcers, they are called as HSV epithelial keratitis. Now both these HSV dendritic ulcer and HSV geographic ulcer, they are HSV epithelial keratitis, and for them the drug of choice is topical acyclovir. But if I ask you HSV stromal keratitis or HSV disciform keratitis or HSV endothelial keratitis, what is the drug of choice for these three? HSV stromal keratitis, HSV disciform keratitis and HSV endothelial keratitis. What is the drug of choice for these three? Please remember that the drug of choice for these three is topical steroids. For this, the answer is topical steroids. This is very, very important. Commonly asked question, commonly students get it wrong. So please remember, for HSV epithelial keratitis, there are two types of epithelial keratitis, dendritic and geographic. For them, the drug of choice is topical acyclovir because it is caused by an actively replicating virus. However, HSV stromal disciform and endothelial keratitis are caused by an immune reaction to the viral antigen, and therefore the drug of choice is topical steroids. Okay, let's go to the next question. Phacomorphic glaucoma is caused by, very, very common question. Phacomorphic glaucoma is caused by nuclear cataract, mature intumescent cataract, hypermature sclerotic cataract, or hypermature Morgagnian cataract. Tell me, phacomorphic glaucoma is caused by? Correct. It is caused by mature and intumescent cataract. So the mature intumescent cataract means it's a swollen lens which pushes the iris forward and closes the angle. So this is a swollen lens which pushes the iris forward and closes the angle. So this mature intumescent cataract causes phacomorphic glaucoma. And the way you people have confused is with a hypermature Morgagnian cataract. See, hypermature Morgagnian cataract causes phacolytic glaucoma. And also remember, what is the other name for phacolytic glaucoma? The other name for phacolytic glaucoma is lens protein glaucoma. Is lens protein glaucoma because in this, the lens proteins, they leak out and they block the pores of the trabecular meshwork. So see, phacomorphic glaucoma caused by mature intumescent cataract, phacolytic glaucoma or lens protein glaucoma caused by hypermature Morgagnian cataract. Very, very, very Commonly asked questions. Next question. Where do we get to see sunflower cataract? Where do we get to see sunflower cataract? Diabetes, galactosemia, myotonic dystrophy, Wilson's disease. Where do we get to see sunflower cataract? Okay, sunflower cataract, good. Many of you are getting right. It is due to Wilson's disease. Now, we all know Wilson's disease is because of deposition of copper. So, in Wilson's disease, we get to see sunflower cataract. What is the other ocular feature seen in Wilson's disease? The other ocular feature seen in Wilson's disease is KF ring. And this is because of deposition of copper at the level of the Descemet's membrane. All these are MCQs. So in Wilson's disease, we get to see sunflower cataract. The other ocular sign of Wilson's disease is KF ring, which is because of copper deposition at the level of the Descemet's membrane. At the level of the Descemet's membrane. At the level of the Descemet's membrane. Okay. Now, taking the opportunity of this question, tell me if I give you snowflake cataract is seen in which option will you mark? In which condition do we get to see snowflake cataract? Snowflake cataract typically is described in which of these four options? Correct. Snowflake cataract typically described in diabetes mellitus. Snowflake cataract is typically described in diabetes mellitus. Oil droplet cataract is described in, where do we get to see oil droplet cataract? Oil droplet cataract is described in, oil droplet cataract is described in, correct, galactosemia, and in myotonic dystrophy, the cataract that we see is called as the Christmas tree cataract. It is called as the Christmas tree cataract. Okay, so diabetes, snowflake cataract, galactosemia, oil droplet cataract, myotonic dystrophy, Christmas tree cataract, and Wilson's disease, sunflower cataract. Okay, let's go to the next question. Okay, where do we get to see rosette cataract, by the way? Where do we get to see rosette cataract? Rosette cataract is seen in, where do we get to see rosette cataract? Blunt trauma, very good. So rosette cataract, this is seen in blunt trauma. It is seen in blunt trauma. Blunt trauma, rosette cataract. Next question. Where do we get to see posterior lenticonus? Which of these options is correct about posterior lenticonus? Alport's, Downs, Lowey's, or myotonic dystrophy? Which condition do we get to see posterior lenticonus? Posterior lenticonus, if we get, we have to mark Lowey's syndrome as the answer. For posterior lenticonus, we will have to mark Lowey's syndrome as the answer. And if you get anterior lenticonus as the question, then you mark Alport syndrome as the answer. If you have anterior lenticonus, then you mark Alport syndrome as the answer. Okay. So if it is posterior lenticonus, you mark Lowey's syndrome. If it is anterior lenticonus, you mark Alport syndrome. Okay. Next question. Sauce and cheese retinopathy, which is also called as pizza pie retinopathy. Sauce and cheese retinopathy, which is also called as pizza pie retinopathy. This is typically seen where? Toxoplasmosis, HSV retinitis, CMV retinitis, or sarcoidosis. Very, very typical question. Correct. It is seen in CMV retinitis, that is cytomegalovirus retinitis. So in this, some areas of the retina appears to be red because of hemorrhages and some areas are white because of this retinal necrosis. So that white and red gives this impression, that is sauce and cheese retinopathy, which is also called as pizza pie retinopathy. Now if I ask you this question, in which condition, the same options, do we get to see headlight in fog appearance? Headlight in fog appearance. Same option. Which one will you mark? Headlight in fog appearance. Correct. This is the typical description of Toxoplasma retinochoroiditis. Headlight in fog appearance. The typical description for Toxoplasma retinochoroiditis. So pizza pie retinopathy or sauce and cheese retinopathy for CMV retinitis. Headlight in fog appearance for Toxoplasma retinochoroiditis. Next question. Bilateral granulomatous panuveitis with vitiligo and tinnitus. This is typically seen in, this is the typical description for sympathetic ophthalmia, weak age disease, ankylosing spondylitis or sarcoidosis. Okay, this you may not be knowing. I'll tell you what this is. This is the typical description for weak age disease. Now, weak age disease is Vogt Koyanagi Harada disease. Vogt Koyanagi Harada disease. Now, see, I'll just tell you a few things which can come as with respect to this question with disease. This is an oculoneurocutaneous disease. Oculoneurocutaneous disease. So there are ocular features, there are neurological features and skin features. Okay? So this, what are the ocular features? See, the ocular feature is this, granulomatous panuveitis. Granulomatous panuveitis is the ocular feature. What are the neurological features? The neurological features are tinnitus and encephalopathy. Tinnitus and encephalopathy, these are your neurological features. And what are the cutaneous features? The cutaneous features are vitiligo, alopecia and poliosis. Poliosis means graying of the eyelashes. So vitiligo, alopecia and poliosis, these are the cutaneous features. So the ocular features are granulomatous panuveitis, neurological features are tinnitus and encephalopathy, cutaneous features are vitiligo, alopecia and poliosis. So all this together, this is VKH disease, right? Now, sarcoidosis also presents with panuveitis, that is correct, but it doesn't present with the other signs that we have mentioned here. So, you are correct that panuveitis, granulomatous panuveitis is also seen in sarcoidosis, but it doesn't present with the other features. Okay, let's go to the next question. What is the drug of choice for uveitis? Simple question, but it's a question which students commonly get wrong. What is the drug of choice for uveitis? What is the drug of choice for uveitis? Correct. The drug of choice for uveitis is steroids. It's always and always steroids. Right? Now, if I ask you what is the adjuvant of choice? What is the adjuvant that needs to be given in all cases of uveitis? The adjuvant that needs to be given in all cases is atropine. Atropine is the adjuvant. Why? Because atropine is a cycloplegic and it helps to relieve the pain. Which is again very, very important. So the drug of choice means something which is going to change the course of the disease. That is uveitis. Therefore, the answer is steroids. It is going to change the course of the uveitis. But atropine is the adjuvant of choice because being a cycloplegic, it is going to relieve the pain of the patient. Okay, sure. Next question. Where do we get to see Dallen-Fuchs nodules? Again, very, very common one-liner. Where do we get to see Dallen-Fuchs nodules? These are actually, okay, let me see how many of you know the answer. Where do we get to see Dallen-Fuchs nodules? Yes, Dallen-Fuchs nodules are seen in sympathetic ophthalmitis. Now, sympathetic ophthalmitis is also a type of bilateral granulomatous panuveitis. So here also we get to see bilateral granulomatous panuveitis, and here we get to see these large nodules which are called as the Dallen-Fuchs nodules. Okay, now a few important one-liners about sympathetic ophthalmia. Now, what is sympathetic ophthalmia? You all know that sympathetic ophthalmia means that there is a severe trauma in one eye, as a result of which there is a uveitis developing in the other eye. So from here, the question that is asked is, what type of trauma causes sympathetic ophthalmia? Let me tell you, the trauma that causes sympathetic ophthalmia is penetrating trauma. This also is asked in exam. Trauma which causes sympathetic ophthalmia is a penetrating trauma, and the area that is to be traumatized is the region of the ciliary body. So if there is a penetrating injury to the area of the ciliary body, then there is a possibility of getting sympathetic ophthalmitis. That is a severe uveitis in the other eye also. Okay. Next question. Where do we get to see 100-day glaucoma? Do we get to see it in CRAO, CRVO, retinitis pigmentosa or Stargardt's disease? Where do we get to see 100-day glaucoma? Correct. It is seen in CRVO. Now see, it is actually the end stage neovascular glaucoma. The end stage neovascular glaucoma, which is seen in untreated CRVO, and this is called as 100-day glaucoma because it happens around 3 months after the CRVO. So if there is a CRVO and it is left completely untreated, then over a period of 3 months, it has this potential to progress to an end stage neovascular glaucoma, and that is why it is called as 100-day glaucoma, because it is happening at the period after about 3 months. Right, 90-day glaucoma also it is called. So it is the end stage neovascular glaucoma which happens after 3 months in a case of untreated CRV. Next, where do we get to see cattle tract sign? CRAO, CRVO, retinitis pigmentosa, and Stargardt's disease. Where do we get to see cattle tract sign? Cattle tract sign is typically described in, correct, it is typically described in CRAO, central retinal artery occlusion, typically described in CRAO. Where do we get to see Harb's striae? Harb's striae, these are striae on the Descemet's membrane of the cornea. So these are seen on the, these are striae which are seen due to stretching on the Descemet's membrane of the cornea. Where do we get to see this? Harb's striae typically seen in ophthalmos, that is congenital glaucoma. So ophthalmos or congenital glaucoma, this is where we get to see Harb's striae. So these are striae on the Descemet's membrane of the cornea, and please remember these Harb's striae, they are horizontal in direction. They are horizontal in direction, and we remember it as H for H. So these are striae on the Descemet's membrane seen in ophthalmos, and they are horizontal in direction. Now, what are the striae that are seen in Keratoconus? In Keratoconus also you see striae on the Descemet's membrane. They are called as Voigt's striae. So if we get the question Voigt's striae are seen in Keratoconus. Now please remember these are also seen in the Descemet's membrane. These are also seen in the Descemet's membrane, but their difference from Harb's striae is that they are vertical in direction. So just like H for H, this is V for V. So these are also striae on the Descemet's membrane which because of stretching, but they are vertical in direction. So Harb's striae horizontal, Voigt's striae vertical. Okay, next question. In which condition do we get to see polychromatic luster? Polychromatic luster is seen in which type of cataract? In which type of cataract do we get to see polychromatic luster? Correct. Polychromatic luster is seen in complicated cataract. Also, if you get this question, breadcrumb appearance. Breadcrumb appearance is also seen in complicated cataract. Breadcrumb appearance and polychromatic luster, both of them are seen in complicated cataract. What is the most common cause of unilateral proptosis in children? What is the most common cause of unilateral proptosis in children? What is the most common cause of unilateral proptosis in children? Correct. It is orbital cellulitis. Most common cause of unilateral proptosis in children. Most common cause of proptosis in children is orbital cellulitis. And if I ask you what is the most common cause of unilateral or bilateral proptosis in adult? Unilateral or bilateral proptosis in adult. Most common cause of unilateral or bilateral proptosis in adult will be? Most common cause of unilateral or bilateral proptosis in adult is thyroid ophthalmopathy. Correct. So most common cause of proptosis in a child is orbital cellulitis, and most common cause of proptosis, whether unilateral or bilateral in an adult patient, is thyroid ophthalmopathy. Next question. Most common intraorbital tumor in an adult, or I should say most common benign intraorbital tumor in an adult. Mind you, I am talking about orbital, not ocular. Most common benign intraorbital tumor in an adult. Correct. Most common benign intraorbital tumor in an adult is cavernous hemangioma. And if we are asked most common benign intraorbital tumor in a child, it is dermoid. Most common benign orbital tumor in a child, then the answer is dermoid. Okay, so most common benign intraorbital tumor in an adult is cavernous hemangioma. Most common benign intraorbital tumor in a child is dermoid. Next, which is the most common intraocular malignancy in an adult? Most common intraocular malignancy in an adult. The answer is choroidal metastases. So the most common intraocular malignancy in an adult patient is actually not a primary condition, it is secondary. Most common intraocular malignancy in an adult is choroidal metastases, and most common intraocular malignancy in a child is retinoblastoma. Most common, now see this is ocular, inside the eye. Most common intraocular malignancy in a child is retinoblastoma. So most common intraocular malignancy in an adult is choroidal mets. Most common intraocular malignancy in a child is retinoblastoma. What is STI? What is STI? Acute infection of the gland of Zeiss, acute infection of meibomian gland, chronic granulomatous inflammation of the gland of Zeiss, or chronic granulomatous inflammation of the meibomian gland. What is a STI? The other name for STI is external hordeolum. What is it? STI or external hordeolum, what is it? Correct. It's an acute infection of the gland of Zeiss. So acute infection of the gland of Zeiss is STI or external hordeolum. Now where many of you have gone wrong is this. Acute infection of the meibomian gland is an internal hordeolum. So that's not external hordeolum or STI, that is internal hordeolum. Okay, so acute infection of the meibomian gland is internal hordeolum. Acute infection of the gland of Zeiss is the external hordeolum or STI. And chronic granulomatous inflammation of the meibomian gland, this is a chalazion. Chronic granulomatous inflammation of the meibomian gland, that's a chalazion. So external hordeolum, acute infection of the gland of Zeiss. Internal hordeolum, acute infection of the meibomian gland. And chronic granulomatous inflammation of the meibomian gland is a chalazion. Okay, so these are a quick set of one-liners that I wanted to discuss. And see, one-liners never go out of fashion. So that's why we can, of course, we should be doing clinical case scenario-based questions, image-based questions. But I think for all subjects, not just ophthalmology, do spend some time before the exam to just run through the one-liners. Because if you get one-liners and you lose them, it's a huge loss. If you know, it hardly takes like 10 seconds to answer the question. So that's why please do not ignore the one-liners in any subjects, not just in ophthalmology. Right, so before I close the session, I just want to show you this. See, we are having this batch from the 16th of September. This is exclusively for students who are appearing for this December FMG exam. And here we will be, it is a short last mile revision batch which is going to be done over 3 months. That is just before the exam, less than 3 months actually, 2.5 months maybe. And it is a well structured batch where we will be doing all a high revision of all the 19 subjects. And there is also this QBank that is available now, and this is going to help you with all the new types of questions that will help you to assess your preparation and also to become more exam ready. Right, so this is this last mile revision batch for FMG December 2022. So thank you very much everyone for being a part of this session. If you have not still downloaded the app, then please do download the app, and you can all become a part of our Plus platform. And for enrolling for the Plus subscription, you can use my code. My code is Dr Sudha. So thank you very much everyone. We will be having more such quick revision sessions over the next 2 months before the FMG exam, and hoping to see you in those sessions also. Thank you very much. Bye bye.